Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hey everyone, welcome to Cracking Cancer. I am your host, Dr. Kyle Concannon, physician scientist now at the University of Colorado, and I am here joined with patient Samantha Murrell. Samantha, maybe you can introduce yourself again.
Hey everyone, I am Samantha Murrell and I am a patient advocate. I have stage 4 non-small cell lung cancer with a HER2 mutation, and I'm happy to be here.
Well, we're happy to have you as always, and you're a great person to be chatting about this because today's topic is going to be what is lung cancer. I think there's a lot of misconceptions about lung cancer. People have a lot of assumptions about what causes it, what it looks like, what treatment looks like, and the kind of patient persona around a lung cancer patient or one who has lung cancer. And I think you challenge a lot of those things and offer a lot of light to those misconceptions. So I'm happy to dive into it with you today.
Excited.
Yeah, so I'm going to let you lead off here. You know, I have some ideas of the things we should probably cover. As a thoracic oncologist, I see exclusively lung cancer. So and my work in the laboratory is exclusively working in lung cancer, working on better treatments and stuff like that. So hopefully I can answer your questions. But yeah, let's dive right in. What questions do you have?
Okay, let's start with the basics on how lung cancer forms in the lung.
Okay. Yeah, I think that's great. You know, to get at that, I think we have to first really understand what cancer is. So when we say lung cancer, like what is this process? Mm-hmm. And we've gone through this in a different episode, but as a kind of a brief maybe update or, you know, for those who haven't seen it, when we say cancer, what we're usually referring to is kind of a process. So this is a process that occurs when the parts of your body, the cells, kind of a smallest unit of tissue, becomes, we say, cancerous. That means that they start dividing uncontrollably. They lose that ability to be where they are in your body in space over time and stay there normally, happily, and then they start to divide uncontrollably. So they develop sometimes a clear mutation. Other ways they can become abnormal. But all pathways that lead to this process we call cancer are occurring because the cell lost its ability to stop itself from dividing. Usually your body has tons of checks and balances in place. The stuff that's around it provides signals. You know, it's confined by pressure, by space, and it loses its ability to regulate based on those things. And then it can sometimes develop these other issues or these other abilities where it can leave where it started, grow through tissue planes. Your other cells don't do that. It can enter the bloodstream, land other places. Your other cells don't do that. So these cancer cells can become very adaptive to the environment and to keep facilitating this ability to grow uncontrollably. So when we say lung cancer, we mean a tissue in the lung, it started in the lung, that developed this ability to divide uncontrollably and no longer respect the borders of what it means to be lung. And that's true of other tumor types too. And when we say lung cancer, what we really mean is something that was originally in the lung. Sometimes you'll see cancers that started elsewhere and then they end up in the lung. That happens quite frequently.
Yep.
Those are not lung cancers. If it was liver cancer, it's something that started in the liver and then spread to the lung, we would still call that a liver cancer. But we would say it spread or metastasized to the lung. So when we say lung cancer, we mean something that was originally in the lung. Was that kind of a clear explanation of what we mean when we say lung cancer?
No, that definitely helps. And my next question is, I know we've covered this in another episode, but I think it's pertinent to talk about it here too, is you'll hear a lot of times that a nodule in the lung, could it be cancerous or not cancerous? Or does lung cancer always start out as a nodule before it grows into a bigger mass. I don't know if I'm using the appropriate terms, but
Sure.
can you talk a little bit about that? Because I think a lot of people out there, oftentimes a nodule is seen on a scan, and people get concerned, is it cancerous, is it not?
The vast majority of nodules that are in the lung are not going to be cancer.
Okay.
The lung has this process that it uses to wall off stuff that isn't native, like the stuff you inhale. It'll wall that off and turn it into what looks like a nodule.
Okay.
When we say nodule, what we mean is that someone had some form of imaging, like a CAT scan or an X-ray, and you just see something that's more dense than air. And usually they're kind of circular looking. So that's all really a nodule is. It's kind of a radiographic finding. It's something we see on a scan. It doesn't necessarily tell you what it is. Now, there are some features in a lung nodule that can be a lot more strongly associated with lung cancer, things like spiculation, where you see kind of projections coming out. That's literally the cancer kind of growing. But generally speaking, when we say nodule, it's a radiographic finding, and the vast majority are not cancer. And it can be things from infections that your body has walled off as part of a natural defense, just inflammation from something that's not an infection, but maybe your body walled something else off. There's a lot of things it could be. Rarely is it cancer, but since cancer is the one of those things that's the most dangerous, that's usually the thing that's on everyone's mind, including the healthcare team. When we see a pulmonary nodule, our first thing is that cancer or is it not? Usually it's not. And for someone who sees a nodule reported on their scan, a lot of times they'll mention if it's clearly cancer or strongly associated with cancer radiographically, like, does it look like it's cancer or does it not? And a lot of times if it doesn't, they'll say low risk, monitor. They'll give some hedging thing because sometimes cancers don't always look like cancers.
Right.
So a lot of times we'll monitor because the risk is so high if you missed it.
That's super helpful. That really helps. And then before we dive into the different types of lung cancers, can we talk a little bit about primary tumors in the lung? So, there are some people that I know, including myself, that have teeny tiny primary tumors, and other people have these monstrosities. Why is that?
Yeah, great question. I don't always know,
Yeah.
really. I think that's something that we need to better understand because what you're mentioning is we may see a really, really large tumor that hasn't spread.
Exactly.
Yeah, I
Exactly
mean,
right. Yeah.
you can get this big thing that's 15 centimeters.
Yeah.
And then we'll check the lymph nodes to see if it's gone to lymph nodes. We'll scan the rest of the body. And it's like, no, it's just this big thing that never learned the ability to spread.
Yeah.
Usually, something's ability to spread is correlated with how big it is. Like the bigger stuff had more time, maybe, and it had more time to mutate and learn these new tricks, but not always. Sometimes they learn them quick.
Yeah.
And then you might even get situations where someone has a lung cancer where it's many small nodules at this point. When you look at it at the scan, you just see small little focuses of lung cancer, and there isn't one big primary thing.
Yeah.
Maybe one's bigger than the other ones, but to me that signals that something about that cancer had an ability to spread early in its development and its growth. A lot of times we see that more commonly when things have these driver mutations, meaning a piece of lung developed one mutation that caused the cancer to grow. And you have one of these with her too. Other ones would be EGFR, ALK, things like that. And sometimes those can spread quickly. But what the actual mechanism is, maybe someone knows, I'm not sure. And we certainly haven't figured out an ability to target that.
Yeah.
Although that would be the hope. If you could find something that prevents cancer from spreading, we would invest a lot into developing that for sure.
Yeah. No, that's super helpful. I think when people are newly diagnosed with lung cancer or they're trying to figure out lung cancer for a loved one or friend, they always have questions around the primary tumor and like, does the size matter and what does that mean and all the questions around the primary tumor. So that is helpful insight.
Yeah, and the reality too is that the stuff that left the primary tumor, if a cancer has spread, so if someone has lung cancer that is beyond stage 1 and has grown to other stages, then those other areas where cancer is developed may look different. Like if I biopsied a piece of lung cancer that spread from the lung and went to the liver, it may be different than the part that stayed in the lung. So what you're seeing with lung cancer and other cancers is really evolution in real time. So a little one cell of the billions and billions of cells that are forming all the lung cancer changes and it spreads and it mutates more, and then you have more evolution. So that's one of the things that makes cancer inherently really, really hard to target, is that some things that might be effective for 99% of the cancer are not effective for the 1%. And then that creates a evolutionary bottleneck. And then, it's a mass extinction event for the cancer. But then the thing that grew out is resistant. And, it's the same as other mass extinction events with other organisms is, let's say you get a plague that affects certain insects. Well, then you get an insect that's resistant and it takes over. Same thing happens with cancers, including lung cancer.
All right. Well, let's dive a little bit deeper into the different types of lung cancer. So, when I was newly diagnosed, I definitely did not know the difference between small cell and non small cell. I was just told I had non small cell and kind of nodded my head because I really didn't know the difference. So, if you could dive into what each one is and the differences, that would be great.
Yeah, I think people are frequently confused by the different types of cancers. And this is one of those things that I think it is worth knowing. There's a lot of details in cancer that maybe not worth knowing, but the details around the different subtypes of lung cancer really matter a lot. The first primary cause of lung cancer is called non-small cell. And that first differentiation point is non-small cell versus small cell. And the reason that's important is because small cell, which is about 15% of lung cancers, that's really, really aggressive. It's the most aggressive subtype of cancer that we know. And the median, meaning average, amount of time that a patient may respond to their initial treatment is 6 to 12 months. So a lot of times what we'll see with small cell lung cancer is it will actually respond really well to treatment at first, but then it will grow very aggressively after. Now, that's not all patients. Some patients do have long-term responses, particularly because we have new therapies for small cell now that we didn't used to have. But it's really important because it's such an aggressive disease that we put it in its own bucket. The other bucket, which is 85% of cancers, of lung cancers, is non-small cell. And they're named this way because of how they look under the microscope. Small cell really is smaller. It really does look more aggressive under the microscope.
Oh, okay. I didn't know that.
Yeah, they actually are, and they do look more aggressive. They also, I've done a lot of experiments in the laboratory with small cells and non-small cell lung cancers. They behave differently. They're truly different. The non-small cells are what most lung cancer is. And these can still be aggressive. I wouldn't assume that because you don't have small cell that things are necessarily going to be easy. No lung cancer is good. So in this 85% bucket, we have non-small cell, and that has adenocarcinoma, squamous cell carcinoma, large cell carcinoma, and then a smattering of other things that are rare. Most of non-small cell lung cancer is comprised of adenocarcinoma, which is the type of lung cancer that usually harbors mutations that we can target, and squamous cell carcinoma, which is the type that's more commonly associated with smoking and stuff that you're going to inhale that's going to cause a lot of inflammation over time. Those are the two most common elements of non-small cell lung cancer, and what most people think of when they think of lung cancer. So around those buckets of the different types, small cell 15%, non-small cell 85%, what questions do you have, Samantha?
Um, what is large cell carcinoma?
Large cell is interesting. So Small cell is really aggressive because it kind of has a different origin, I'll say. Or I don't know if it's aggressive because of that, but one of its primary features is it has what we call neuroendocrine features. Now, it's not saying it's a neuronal cell or endocrine cell that secretes stuff to everywhere, but it was derived evolutionarily when you're developing from kind of a different origin than some of the other lung cells. And for whatever reason, this is a lot more aggressive. It's usually caused by smoking.
Okay.
Large cell carcinoma actually looks a lot like small cell, except so it has a lot of the same features. If you look at it under the microscope, they can look really similar. But as the name implies, they tend to be a little larger. So it's almost like a mix between non-small cell and small cell. Large cell is also aggressive.
Okay.
So large cell usually is treated the same way small cell is, but based on the nomenclature and how we named things back in the day, it didn't fall in the bucket that was small cell, so they put it over here.
Okay.
Yeah, although large cell carcinoma, it's not super common, but it is still a very aggressive tumor that's commonly treated like small cell lung cancer.
Interesting.
And we bucket large cell and small cell as these neuroendocrine types of cancers. So they both have those features, and they're both aggressive. So the distinction was probably one historic, but treatment wise, they're treated pretty similar. They act pretty similar. And then clinically, the distinction for a patient is like, do I have adenocarcinoma, squamous cell, or one of these other ones that are a little more rare?
Yeah.
Those are probably the ways I would look at it if I were newly diagnosed.
So with adenocarcinoma, I believe that exists in other cancers as well. Is that correct?
Yeah, adenocarcinomas are usually things that are kind of secretory.
Okay.
So stuff that's like around mucous membranes or things like that. And so, you can get adenocarcinoma of many different types. And squamous cell is true as well. Like the most common squamous cell is probably the skin.
Oh,
So
I
squamous
see.
cell is kind of like barriers,
Okay.
things that aren't secreting stuff. But in the lung, the I think of the squamous cell carcinoma as being, the lining of the bronchus, the airways. And then you have the kind of mucus secreting cells in the airways that can become adenocarcinomas. And, is the distinction super important from a cell of origin perspective? For the patient, not so much. Like, I wouldn't focus so much on adenocarcinoma squamous cell, although I would keep them in a bucket of these tend to do better. Beyond that, we get to things that are like targetable. So, on one hand, you have this question of what is my tumor really? And when people come to see us for second opinions, their first question is usually, do I have what they said I have? That's like usually what people want to know is they biopsied my lung. They said I have lung cancer. Do I really have lung cancer? And most of the time, the answer to that is yeah. Most of the time, the diagnosis is correct. But you can get differences in is it, mostly adenocarcinoma? Is it mostly squamous cell carcinoma? Sometimes those can be mixed. You can get nuances that aren't going to be really important for driving treatment decisions. And what we care about next is what elements of the tumor can influence what we're going to do to treat it. Because for most lung cancer, if the cancer has spread, chemotherapy is somewhere in your course. Most people are getting chemotherapy. It's still the biggest kind of heavy lifter of cancer treatment for those who are not small enough to be cured with surgery or radiation. And even the ones that are small may still get chemotherapy. So the distinction I have usually initially is somewhat as these different types, which we call histology, meaning what it looks like under the microscope. But we've advanced now where we can go beyond that and say, beyond the histology or its type, does it have any unique features that we can use to influence what we're going to do?
That's super helpful. I do have a question though, because you talked about biopsy and it coming up as adenocarcinoma or whatever type of lung cancer you might have. Do you have any advice to people who maybe had a biopsy? And I know we're going to go into symptoms and signs of lung cancer, but say they have signs and symptoms of lung cancer, they had a biopsy and the biopsy came back as not having anything. I know of quite a few situations where that happened initially. Maybe it was just a bad biopsy or the wrong bit of tissue was taken. What advice do you have for someone who is like, I'm pretty confident I have a cancer going on, but my biopsy is not coming back as having anything?
Yeah, that's a tough question. So, and I would say for the individual who has a pulmonary nodule that they're convinced is cancerous, meaning it's changing on a scan, or you have some objective measure that says this is high risk, not just the anxiety, because the anxiety is very real. So if you're really convinced that it's a tumor, but the biopsy was negative, we'll usually monitor it with a close scan. So at some interval, a couple of months, we'll do another scan to see if it's growing.
Okay.
Now, if it's not growing, you don't really have to be as worried about it. Maybe you'll do another scan at some other interval, but cancers tend to grow. Like that's what they do.
Yeah.
Now, if that does come back, the next scan does come back showing that it is growing, we're going to do another biopsy most likely. That being said, sometimes there are tumors that are biopsied. On the scan, they look like they're cancer. We're convinced that biopsy is going to come back positive and it's not. Now, sometimes the report will say insufficient tissue. Like we don't have enough of the things that we would expect to see for me to be confident that the area was appropriately targeted with a needle. Because like we say lung cancer as though it's one thing, but sometimes the lung cancer is in the center of the chest. Sometimes it's on the side of the chest. Sometimes it's, the top or the bottom. And those are, different levels of difficulty in how you're going to get a good biopsy. So there is a real risk of a inaccurate biopsy that says it's not cancer, but it is. And those are situations where you may go back and just try again right now. But that's a conversation to have with the care team. And I think the way to navigate that is to say, what level of certainty do I have that this is going to be cancer? If it's really, really high, then maybe you do proceed with the extra risk. But it's a judgment call,
Yeah.
It would be just as reasonable to say, man, let's check the scan again in 2 months. And if it's growing, but what patient wants to sit with something they believe is cancer
Yeah.
and just say, let's watch it grow?
Right.
That's a pretty distressing outcome.
That's very distressing.
Like we get that.
Yeah.
So yeah, it's all a judgment call. But
Yeah. I
but
think that's
those are
good
the
advice.
those are the things I would weigh.
Okay. Which leads to us discussing symptoms and signs of lung cancer. I can talk about mine all day long, but if you want to talk about the, I guess the main signs and symptoms that most people see in lung cancer.
Yeah, I'll go into it, but I think the symptoms that you had were pretty common. So maybe we can start with, Samantha, can you tell me the
Sure.
symptoms that you had from your lung cancer when you were diagnosed?
Sure. So, I had two phases of my diagnosis really. My 6 months prior to my diagnosis, I actually had a blood clot, which was my first sign of having lung cancer, but no one at that time thought that meant I had cancer because there was no reason to believe that it was cancer. But 6 months later, I started to develop some chest pressure and a cough. I had also lost about 5 pounds of weight, but that's pretty substantial for someone of my size. So 5 pounds was a lot. And I mean, my cough and the chest pressure only lasted like 2 or 3 weeks before I went to the doctor. And I was fortunate enough, very much not the case for the majority, unfortunately, that they immediately did an x-ray to figure out what was going on. And that x-ray showed an entire lung full of fluid, which initiated further discovery, I guess, of what was going on with me. So I was very, very fortunate. I know a lot of people, especially in the younger side of things, who went sometimes years with a cough, weight loss, and other symptoms that, because they were so young, that doctors didn't put two and two together and would maybe give them antibiotics because they thought they had pneumonia, or told them they just had anxiety, that fun one. But it's really scary because I feel like lung cancer symptoms really go under the radar a lot of times, and can be attributed to many other different things, which make people not discover it as early as it could be found.
Yeah, I think you're totally right. In someone who is younger like yourself, the symptoms of lung cancer are most commonly from something else.
Yeah.
It's rare that someone who's a younger individual, 30s, 20s, 40s, who doesn't smoke is going, that's going to be lung cancer.
Right.
That's
Right.
a tough one.
Yeah.
And I'll say in you had this thing called an effusion where fluid developed around the lung, and that's really abnormal. So they actually saw on the chest x-ray something clearly abnormal.
Right.
For a lot of people, they get that chest x-ray and it looks pretty clean. It looks okay.
Yeah.
Because the ability of a chest x-ray to detect lung cancer is not good. So they can miss it.
Yeah.
This happens a lot. And no, this isn't to be a negative assessment of the people in the community who are working up these symptoms. It's to say it's hard to diagnose sometimes. But the symptoms that you had are the classic symptoms. You have localized symptoms, which is like there's a tumor in the airway, the actual air pipe, that's causing disturbance, that causes a cough. Like you feel irritation in there, and it's tough you can't clear it. But when you breathe in, there's resistance because the tumor's there. So that can cause chest discomfort, that can cause a cough, it can cause irritation, and that can feel really bad. And then you have the symptoms of the tumor, meaning the tumor is a biologic thing. It's taking up nutrients. It is releasing materials that make you feel bad. So you experienced that with a blood clot. Tumors notoriously cause blood clots. And was your blood clot in your lung?
No, it was in my cough.
Right. So that's the most common thing, is it's actually not because the tumor itself is causing a local problem. It's because the tumor makes the blood more likely to clot.
Right.
Your blood is a balance of things that are dissolving clots all the time and things that are preparing to make clots all the time. And they're in a good balance. The tumor tips that. So people can get blood clots, but then they also get the weight loss, the fatigue, and these are just from the metabolic demands of tumor.
Right.
So when people think, I'm going to starve my tumor or things like that, I'm going to change my diet to an anti-tumor diet, pretty unlikely. Your tumor is going to keep growing and it's going to metabolize the other stuff in your body, your
Right.
muscle, your fat stores, things like that. The tumor is going to grow. So, and you felt that. You lost the weight. The tumor didn't go away
Right.
despite you losing weight. Like that's the
Right.
process that occurs. So those I would say are the common symptoms. And it's tough because those can be symptoms of a lot of things. I mean, if you had pneumonia, those are the symptoms of pneumonia. And pneumonia also occurs in the lung. It's very common and it occurs in smokers. So people who smoke tend to get pneumonias. They get COPD exacerbations. And it's really hard to differentiate sometimes. Is this an infection or is it a cancer? And that's why you see so many times there's a trial of antibiotics, a couple of weeks, maybe do another one. It didn't really go away. Okay, maybe now I do see something that looks more like a nodule. Didn't really appreciate that before, but now that I'm looking carefully for something atypical, it's coming out. And a lot of times that is how lung cancers are suspected, and then you'll undergo the process for diagnosis.
Yeah, and I think an important point is that you hit on was that x-rays are not the best for seeing lung cancer tumors, because I know a lot of people are like, oh, well, I could just get an x-ray to check and then I'm reassured if nothing is seen. But like on my x-ray, all you could see was fluid. Like you couldn't see any tumors. There was nothing that would say that there was anything suspicious on my x-ray at all apart from the fluid. So I'd say if in doubt, push for that CT scan when you can. And I'll forever live with this because when I did have my blood clot, they did say we can get a CT if you want to be reassured that you don't have other clots going on apart from your leg, and I declined. And that will live for me with me forever because I'm like, was that my chance to catch it way earlier? And maybe it was, but I know a lot of times people are not offered up CT scans on a platter like I was. And that's the best way to see a lung cancer tumor.
Yeah, and I would say right now the guidelines wouldn't suggest getting lung cancer scans when anyone gets a clot.
Yeah.
Now, but that's not to say that that won't change over time. Like we need more information to see how many people get clots really do have a cancer. And now that we
Right.
know that the incidence of cancer in younger folks seems to be going up,
Yeah.
those guidelines might change,
Yeah.
because everything that is guiding our decision making is 10, 20, 30 years old. We had to have already done those analyses, thought about it for a while, hemmed and hawed, made a decision, and that takes a decade or two.
Yeah.
So I typically would say lean toward the guidelines, but knowing what I know now, the risk benefit of pushing a little more is usually insurance covering it.
Yeah. That's true too.
So that ends up being what drives a lot of decision making these days.
Yeah.
But I agree with your point that my perspective as a patient myself is always to minimize and not want to be a burden and not think of the most high burden, low likely thing. But working in cancer medicine, my perspective around that has probably changed.
Yeah.
And, in all likelihood, your tumor had probably grown. It probably was already where it was if it was causing these symptoms.
Right.
But you never know.
Yeah. You never know.
You never know. Yeah. So I think the guilt around missing diagnoses early is very common in lung cancer
Yeah.
because many, many, many people have delays.
And I will say, we talk about common symptoms of lung cancer, and I know we're going to go into the different stages later on in this discussion, but at stage 4, I hear a lot about individuals having bone issues, and right, and that's what leads to their diagnosis. Actually, it's got nothing to do with the lungs at all. They end up having a very painful hip or excruciating back. And they go through physical therapy and that doesn't work. They're put on, cortisol injections and that doesn't work, and all of these different things. And then they do a scan and find out, unfortunately, it's stage 4 lung cancer. So I know quite a few people that never had the cough. They never had the classical symptoms. It just came down to an area of the body being extremely painful, and that's what led to the diagnosis.
Yeah, that can certainly happen. The symptoms we're talking about are kind of localized symptoms.
Yeah.
But lung cancer likes to spread to places. It likes to spread to bone. It likes to spread to liver. It likes to spread to the brain sometimes.
Yeah.
And people can have symptoms in those areas. It can be a stroke. It can be a broken bone. We call that a pathologic fracture, where you're just walking and your femur breaks.
Yeah.
And then they go in and they see that there was a tumor there. And yeah, it's certainly not a one-size-fits-all diagnosis, and I wouldn't say that if you have hip pain, the most likely cause of your hip pain is not lung cancer.
Right.
But it can happen, and that's why those new symptoms that are lingering and you don't want to be a bother, like always bring those up with your care team. And it also highlights the importance of having a primary care physician that you meet with on some regularity and you trust them.
Yeah.
Like, that person can be the person who hears, oh, okay, you don't usually have hip pain, and they'll do an exam, and that person may say, it shouldn't hurt like this when I touch it. Let's do something else.
Yeah.
And
Yeah.
you can catch the stuff.
All right, let's talk about, and we've kind of touched on this already, but how lung cancer is diagnosed.
Yeah, so usually lung cancer will be radiographically diagnosed first, meaning we have a scan. So a scan will either be, usually it's a CAT scan. Sometimes it can be a PET scan. A PET scan versus a CAT scan. So the CAT scan is when we do like an X-ray up and down, and it's just the traditional lower dose radiation. And what you're looking at is things that are very dense versus things that are not very dense. So your lungs are not very dense. It's mostly air. Tumor is pretty dense. So you can see the difference between the tumor and the lung, and that shows you the cancer. A PET scan shows metabolic activity. So things that are using a lot of sugar, that are eating a lot, these are things like infections can do it, inflammation can do it, cancers can do it. So that will give you a signal that something's abnormal there. And then that'll tell us, hey, why don't we biopsy that? So that's how you kind of get the suspicion that there's a cancer there. And then you go in and, we say tumor's a rumor, tissue's the issue. You need to get a piece of tissue. So you need to get some sampling. Now, usually that's going to be a needle through a bronchoscopy where someone goes through the windpipe through the mouth while you're sedated. And then they take a needle biopsy of the tumor area and then also probably some of the lymph nodes, the areas that drain the tumor and kind of, or drain the lungs and kind of clean the area. That can sometimes get cancer in it too. So they take samplings of those. Alternatively, you can get a needle biopsy from the outside of the lung. So if your tumor is on, the outside, closer to the rib cage, they might have to go through the skin and go that way. We call that a CT guided biopsy, as opposed to a bronchoscopic or a bronchoscopy biopsy. But those are the two ways we typically get the diagnosis. Now, we might also get information from the blood, but that wouldn't at this stage be a diagnostic biopsy. Usually we still need to go in there and get a piece of tissue and look at it under the microscope. Once it's under the microscope, we do all these different stains. So we'll actually put on antibodies and different stains that look at it and say, did this come from the lung? Did this come from the liver? Because I mentioned that a lot of cancer grows and then spreads to the lung. So just because you see a nodule in the lung and you think it's cancer doesn't mean it's lung cancer. And that's something that really has to be differentiated because the treatments are so different between lung cancer and different types of cancers that you really need to iron that out. And that can take some time.
Yeah.
That's distressing.
And for me, I still to this day have never had a lung biopsy. So my diagnosis was done through a liver biopsy because they didn't know what on earth was going on with me. And so they defaulted to a CT guided liver biopsy. So that's what I had done.
Yeah.
So yeah, I've never had a lung one to this day, but the liver one proved that I had endocarcinoma of the lung, so we knew what was going on.
Yeah. And forgive me there. I was talking about the primary lung because we were on the topic of nodules. So yeah, you're totally right. Any tumor tissue that is from the lung cancer can diagnose it as lung cancer. For some people, they just have a lesion in the brain or a bone, or the liver is quite common. And if we see that and we're convinced it's lung, then what you had happen is common. We don't need to go back into the lung and do more biopsies
Right.
to prove what it is.
So can we talk a little bit about molecular testing because it is a very hot topic in lung cancer, and needs to be pushed more often. I almost think it should be a necessity. Just
Yeah.
because of the importance of it. But can you talk a little bit about what molecular testing is, why someone would get it, and why it's so important at the very beginning of diagnosis?
Absolutely. So molecular testing, for those who don't know, is additional information we get on the cancer to determine what's driving it. And many times that information will dictate what we do. And if it isn't obtained, people can get literally inadequate care. So it is, I think, in lung cancer pivotal that you at least have the discussion with the care team of getting molecular testing in a timely fashion, get it quickly. Now, there are caveats in certain elements of lung cancer where the guidelines may not recommend getting that testing. And usually that's from a cost perspective and because in certain types of lung cancer, it may not change treatment. But my argument is that you only know what you know. And if you are making assumptions about your lung cancer and saying, I'm not going to get it because I think it's too small, or I think it's this other type of lung cancer that doesn't usually have these mutations that we change treatment for, maybe you're wrong. Maybe the cancer has already spread and you just didn't see it yet. And maybe, the element, the cancer under the microscope that looks a certain way, maybe it still has some of these driver oncogenes, even though they're rare. So I advocate for molecular testing in everyone.
Yeah.
And what we're specifically looking for are DNA mutations usually. So that's what you have, Samantha, is a HER2 mutation. And when we say mutation, what we're talking about is, you have your cell, the lung cancer cell, on the in the right inside the wall of the cell is the cytoplasm. This is the stuff that, the fluid in there that stuff is happening in. Your mitochondria live in there. Those are the energy powerhouse. But then you get inside the nucleus. And the nucleus of the cell is where your DNA is housed. And the purpose of DNA is it serves as a template. The DNA itself doesn't do much, but it serves as a template for your cell to make protein out of it. So every protein that your body makes has its blueprint in DNA. But when that blueprint becomes altered, it can make an altered protein. And then the altered protein does things it shouldn't do. For example, if HER2 is altered, it may now tell the cell to keep dividing. And if the cell just gets the signal to keep dividing from this mutated HER2, which looks just a little bit different than regular HER2, then it's going to keep dividing, and that's going to be what cancer is. So that's what we're looking for when we talk about molecular testing. And the reason that's so important is because if we know exactly what's causing the cancer, we might be able to have some nuanced abilities to treat it. So molecular testing, I think, is imperative for everyone with lung cancer to get, because I don't like to make assumptions. And the assumptions based on histology or staging, where sometimes you don't necessarily need molecular testing, may be wrong. I've never been upset that I got it.
Yeah, because correct me if I'm wrong, molecular testing is a lot more common in stage 4 diagnosis, but like a stage 1 lung cancer, do you maybe have to push a little bit more to get that molecular testing?
You might, and this is coming down to a financial decision for kind of cost equity. Like and let me mention, for a tumor that's really small, you may be able to get away with just cutting it out, radiating it, and you are cured forever. The molecular testing will actually never be relevant. That's the reasoning behind not getting it. Now, the challenge with that is, what if you're wrong? And for me, at least, I like to know how tumors evolve over time. And it gives me a sense of tumor biology, how aggressive I should be, things like that. And it's easier for me to do that if I had a sense of what your tumor was doing in the beginning. And then let's say you cut out what you thought was all of it, but maybe it wasn't all of it. Maybe there was a little bit somewhere else that we didn't know about. Now, if those are different, then that gives me information. Or, if you thought you cut out all of it and then you find later, a month later, 2 months later, that it was actually in the lymph nodes too, now you already know what to do. And it saves you time on the back end. So I think it's very helpful. There's also the element of cancer research, where we can do research on tumors only if we know what they are. If everyone who had HER2, or let's say half of the people who had HER2-driven lung cancer got their tumors resected, but since they were resected, we never tested them, I would have a lot less idea about HER2 biology because we just didn't know they were HER2 positive. So
Right.
for me, from a working on cancer treatment as a collective, as a community, for me, the more information is the better. Because then we might say, well, what was different about those than yours? And can we target that? But we would never know if we didn't do the testing. So I think there's a lot of reasons to do that molecular testing. And if I were a patient, even if I had a very small tumor, I would absolutely advocate for it. I would try to
And
get it.
and at stage 1, if there is a mutation that's driving your cancer, it will be present in that tissue, correct?
Yes.
Okay.
Yep. The tumor, that's our understanding is that that is what caused the tumor to form in the first place.
Right. Right.
And that mutation will not be in your other cells.
Okay.
The rest of your body will not have it.
Yep.
So that would be a clear difference. Some people have the belief that if they have a mutation, that they were born with it. And rarely that's the case, but that's pretty rare. It's very rare in lung cancer. Usually it is acquired, meaning you got it somehow from something,
Yep.
and we rarely know why.
Which is annoying.
It's annoying. Yeah.
And I do want to say that molecular testing is also called biomarker testing. So that's another term for it that I think is helpful for the audience to know.
Yeah.
Because that word is thrown around a lot. What is biomarker testing and molecular testing, biomarker testing? It's the same thing, but it's just different term that's used.
Yeah. And it can be done from the tumor biopsy or from the blood. We can do it from blood draws. The blood draws are not as sensitive, meaning, when you take a tissue biopsy and you look at it in a microscope and you know it's cancer, well, you know you've got it. But the blood may say there's nothing there because there just wasn't enough of that tissue substance around, of the tumor substance around. So the blood biopsy can be wrong.
And the blood biopsy, correct me if I'm wrong, is more helpful at stage 4, right? I mean,
It is
you're
because
more likely going to get something to hit on that.
usually because there's more tumor.
Yeah,
And the more tumor means there's more shedding DNA
gotcha.
and there's more DNA in the blood that we can check. Because there's a lot of DNA in the blood that is not tumor. The vast majority is your normal cells turning over.
Right,
So we have to
right,
look for that needle in a haystack to say, ooh, there's a little bit of tiny signal here that looks different. We think that's probably the cancer. And if you have a lot of cancer, that signal is louder and we're
right,
more confident that that's really something abnormal. But when you just have a small tumor that hasn't spread anywhere and it's just a low volume of tumor cells, then our likelihood of catching that mutation in the blood is much lower.
So let's talk about common turnaround times for these kind of testing. So I think blood biopsy, molecular testing is like 2 to 3 weeks.
Yeah, I mean, it depends on where you are. Some institutions have their own.
Oh,
Where
interesting. I
I
didn't know
trained at
that.
MD Anderson, we did our own panels.
Okay.
But a lot of places will send it out to a different company and, factor in your mailing time. They have to do it. They have to run their QC, the quality control stuff. So yeah, I would say as quickly as a couple of days, but I would anticipate a couple of weeks.
Okay. And the tissue one takes a bit longer than that, right? Or
I
not
mean, it really depends.
necessarily?
If you're sending it out, almost certainly.
Okay.
But if you have something in house, that could happen quickly. Some institutions are pushing to where when they see that it's lung cancer, they just do it
Yeah.
because they know that everyone should be getting it. And that may be very quick. So it really does depend on where you go. And this is one of the things that it's a bit of a tangent, but I like to tell people that if you think you have lung cancer or any type of cancer, start your course where you want to be treated, where it's feasible. Like think of when it comes to my healthcare or my family's healthcare, I think if you're worried about something happening, what's the worst case scenario? Go where you would go to manage that because you don't want to be transferring care when bad things happen. That's not ideal. So I would say if you're worried you have cancer, I would get my biopsy done at a cancer center because if it's positive, you're there and things will move quickly.
Yeah.
Yeah.
All right, let's talk about staging.
Yeah. So staging generally for lung cancer, like other solid tumors, goes 1 through 4. And I'm going to be general here because there are nuances between the different types of lung cancer. And I don't want to get bogged down in details. But generally speaking, stage 1 is the one that's curable. Almost always. Not always, but almost always. And what we usually mean by that is it's a small nodule that we can cut out or radiate, and we kill or remove all the tumor. So when you get to stage 2, usually that means the tumor is a little bit bigger, harder to cut out all of it, harder to radiate all of it, and maybe it's spread to kind of a local lymph node. And we still can cure those, but we cure them less frequently than those small stage 1 things. Stage 3 means even bigger, more likely to have spread to more lymph nodes, but still potentially curable. Again, less likely. The higher you go in stage, the less likely there is of cure because the tumor has either grown more or spread more. But stages 1 through 3 are still in the lungs. So those are the big distinction. And then we get to stage 4, which we call metastatic. Now, that usually means it's spread from the lung to outside the lung. And that can mean even the lining of the lung, which happened with you, Samantha. That's what was causing your effusion of the fluid around the lung, is tumor had spread there. So while we say metastatic is it's spread outside the lung, a lot of times what we really mean is pragmatically we can't get it all with curative techniques. We can't get everything with surgery. We can't get everything with radiation. So we'll call that stage 4.
And I think that's a really important distinction because I think some people get confused when they're initially diagnosed that, oh, it's in both of my lungs, or oh, it's in one of my lungs and my pleural lining. That means I'm still like stage 3, but in actual fact, because it's jumped to the other lung or because it's gone to the pleural lining, it's unfortunately stage 4.
Yeah, you know, the staging matters a lot, but it is still generally assuming certain things. And what we're trying to get at with staging is what can we do to maximize the likelihood of the best outcome? So we do treatments based on stages, but there's always exceptions to rules. Like if something goes from one lung to the other lung, you may still try to cure that. We generally try to cure what we can. There are other examples. If, let's say, you had a lung cancer and you had one lesion that went to the liver, and that's it, that's the only thing we see, we're going to probably still try to cure you. So there are nuances to everything, but generally the paradigm goes stage 1 folks are a lot easier to cure. And as we progress in stage, harder to cure, the cancer's gotten bigger, it's spread more to lymph nodes, further lymph nodes, and then outside of either the lung lymph node area to somewhere else. And that's what we call stage 4.
And not to get people overly concerned, but just to be aware, I think it's helpful that, especially in lung cancer, right? Like stage 3, it's a fine line there, right? I mean, I know some unfortunate circumstances where a lot of stage 3 people unfortunately went to stage 4 at some point. Maybe it's more so if you have a mutation that happens, but that seems to happen a lot more in lung cancer than other cancers. And I don't know if that's just because lung cancer is aggressive as hell, or why it is, but it seems to happen quite often.
Yeah, I'll say the way we cure people with lung cancer is to largely cut out or radiate every area that has lung cancer. We don't have a lot of therapies that go everywhere that cure. So if you have stage 1, 2, or 3, the way we're going to cure you by and large is by cutting out or radiating everything. Now, your lungs have a lot of lymph nodes. Your lymph nodes line your major windpipe, and then when your windpipe breaks apart, you have lymph nodes down there too. To sterilize all that is actually really hard. And to be convinced that you appropriately sterilized it is tough. So a lot of times when we think we may have gotten everything, we didn't. And there are a lot of folks who are stage 3 who undergo curative treatments who do eventually progress.
Yeah.
So that's a tough reality. And I couldn't emphasize this more strongly, to do probably the most aggressive thing you can tolerate if you're potentially curable, and go to your follow-up scans. Some people will do their therapy and then assume they're done.
Yeah.
And if we see something early growing, our ability to still attempt a curative treatment course is much higher than, once the tumor has spread, if you've given it too much time.
Yeah.
But we still haven't gotten into causes.
Oh, we've got so much, and this is probably going to be a part 1, to be honest with you. But I thought causes could maybe be its own thing.
I think it may have to be.
Yeah. I was going to skip down to treatments, different treatment options.
Yeah, well, I do want to just I think we could do a deep dive in causes, but I want to let people know, the classic association is smoking, and that is true. Most lung cancer is caused from smoking. But Samantha, you're a testament with yourself that not everyone who has lung cancer smoked. The lungs inhale a lot of things, and tobacco smoke is not the only thing that one can inhale that causes cancers to occur. And let's keep in mind that there are other parts of your body that get cancer that are not exposed to the external environment.
Right.
You can get liver cancer, you can get kidney cancer, you can get cancer of any organ. And the lungs are no different. They can get cancer without smoking, without doing the quote unquote everything wrong. So, the other things, the genetic mutations that we've been talking about, those could drive lung cancers, secondhand smoke, air pollution. One of the most common other things that are preventable are radon. It's not a huge percentage, but it is something that you should be, if you have a basement, that's usually where radon will leak out of soil into the basement air. So get your radon checked. These are the preventable things. Now, still, smoking is the most common cause, but even if we eliminated smoking today, lung cancer would still be a top 10 cause of cancer death. And I think that's something that's really important for people to know, is you can't sit on this if there's a concern for lung cancer and you didn't smoke. And the flip side of that, if someone did smoke, they didn't deserve lung cancer. You can still have all the risk factors and it be a tragedy. Many people smoke all their lives and don't get lung cancer. And just because it did happen to someone who smoked doesn't mean they deserved it. So I think anyone going through lung cancer needs as much compassion as we can give them, because it is it's tragic and there's no way around that. But those are, there's a lot more we could go into with risk factors.
Yeah.
But, I think it would be we'd be missing a little bit here if we didn't go into some of the preventable stuff. Usually just make sure you're not inhaling, pollutants, stuff that can cause mutations like secondhand smoke and tobacco smoke and the radon one. I've done my diatribe and my public service announcement. So
There we go.
yeah.
Yeah, we should definitely dive deeper into it on another episode. But yeah, let's talk about treatments then.
Yeah. Yeah. So I think lung cancer is at a great point in its cancer research progression, but also a daunting point because now we have a lot of options. Whereas 20 years ago, it was 3 options. You had chemotherapy, you had radiation, you had surgery. That was it. Those were the only things one could get. And most of them did not work very well. So we're in a much better position now where we have a lot more tools at our disposal. And the staple of curative treatments is still going to be surgery and radiation. That hasn't changed. And those are reserved largely for early stage disease, meaning like stages 1, 2, or 3, or patients who have symptoms. We'll still do radiation in a place that has symptoms. If someone has a large brain tumor and it's causing problems, we'll resect. So a lot of those are what we call palliative, meaning they're intended to palliate or alleviate symptoms. But those are still a heavy staple of cancer treatment is surgery and radiation. Beyond that, we get into the other treatments that go everywhere in the body. One of them is chemotherapy, which many people are familiar with in the general sense, but I'll say lung cancer chemotherapy is actually pretty well tolerated. The perception that people have that they're going to be vomiting all day, their hair's all going to fall out, they're going to be wasting away is by and large not accurate. I think that's a common misconception. I think the chemotherapy that most people get for lung cancer is actually pretty well tolerated and people feel better. And Samantha, you can actually speak to this because you were on chemo. That was your first treatment. How did that go?
Yeah, I mean, I had 4 rounds of something called carboplatin and pemetrexed, and then I also had an immunotherapy that I know you're going to talk about. But the carboplatin was not the best, but it wasn't too bad. Like you said, I didn't lose my hair. I just had some bouts of nausea, but it wasn't debilitating by any means. Wasn't a fun experience. Wouldn't recommend, but if one has to have it, I wouldn't be as afraid of it as maybe the perception is out there on it.
Yeah, and I think the progression of people's ability to tolerate it is because of the other meds we have that make nausea much more manageable. But again, those are things that we can only optimize if we know. So this is a reason to be really upfront with your care team if chemotherapy is in your future, is talk to them early about symptoms because they can be a lot more aggressive with symptom management.
Yep.
But chemotherapy, it goes everywhere. It targets largely dividing cells, and it inhibits a cell's ability to divide. That's like how it functions. The replication mechanism gets messed up. It's not really specific for cancer cells. It's just cancer happens to divide more. That's why there are symptoms. But lung cancer is in the privileged space where we have other stuff now. One thing that might be on the docket for many patients these days is immunotherapy. Immunotherapy is usually what we call immune checkpoint inhibitors. And we have a whole other podcast on this with Dr. Natalie Vokes, which is great. If people are interested in that, they should check it out. But really what these things do is tumor cells put up this signal that says, don't eat me, to the immune system. Because the immune system's always going around and they're clearing things that don't look normal. And I mentioned, cancer cells they mutate, they mess up their proteins, they make things that look weird. And the immune system naturally clears that. The immune system probably cures many cancerous cells every day. Many abnormal things that are growing, the immune cell will come and kill it. But tumors have evolved this ability to resist that by putting up these signals that say, don't eat me. And immunotherapy blocks that. So it lets the immune system re-engage to kill the cancer. On one hand, it's actually really, really good because some people respond very well to these. The immune system goes crazy and it attacks the cancer very, very well. The flip side is some tumors don't really care. Like that signal comes in and they don't respond. Maybe they don't produce the things that the immune system needs to see to view them as abnormal. And unfortunately, many of the tumors that have mutations fall in this category where they're not sensitive to immunotherapy. That's common. The other flip side is immunotherapy can cause pretty gnarly side effects sometimes. And since they work by telling the immune system to ignore these don't eat me signs, their side effects tend to be autoimmune. A lot of times that can be rash, it can be diarrhea, because the colon can be impacted. But rarely it can be, and those things are tolerable and manageable usually. We know how to manage those with steroids and things. But rarely it can attack the lungs themselves. It can attack the heart. It can, rarely cause real damage. So that's a usually really well tolerated therapy that has a lot of potential, but it's not a cure-all, And then for those who do have those mutations, I mentioned immunotherapy tends to not be as effective there, but we have these things called targeted therapies, which are, those are pills usually, which work because they're small molecules that will bind to and disrupt that specific mechanism that caused the cancer to grow. Now, this was such an inspiring thing for me. This was the initial discovery that led me to go into cancer medicine in the beginning. Was when these first came out, I was just like, wow, this is so cutting edge and this is how we should be tackling disease, that it inspired me to become an oncologist. And Samantha, this is like you have this HER2 mutation. The mutation tells HER2 to keep signaling. That signaling tells the cell to keep growing. We now have a drug that can go and bind to it and stop it from signaling. The cancer cell dies, but since nothing else in the body has that HER2 mutation, it's just a tumor thing, you don't really have a lot of side effects. So generally they're well tolerated, certainly compared to chemotherapy. They're not all perfectly tolerated, but it's a class of medicine that we're really proud of in lung cancer, and we're really fortunate to have them. Not all tumors have targeted therapies. So those I would say are the big classes. We also have things that are more cutting edge and new, that are not yet standard of care, like cellular therapies. These are things where we would take someone's immune system and program the immune system to attack the tumor. I've done research in this kind of stuff, and I think it is promising in the future, but it's not ready for prime time quite yet. We have some trials that are evaluating some of the most promising stuff, and I think that's the context in which they should be, evaluated. If you're someone who has access to a trial like that, just be well informed. But it is something that's on the horizon. And then we have many other things. Antibody drug conjugates are another interesting class where we have an antibody that can target the tumor itself. Attached to that antibody is a really toxic chemotherapy, something that would be way too toxic to just give on its own. But since that antibody is very, very specific for the cancer, it's kind of like a targeted delivery system for chemotherapy. And Samantha, you're on one of these.
I am.
Yeah. Fairly tolerable?
Oh, I have my moments, but
Yeah.
yeah, it's fairly tolerable with the right medicines to combat some of my side effects. But it's doing incredible things. I mean, it's shown in my scans, so I'm all about targeted therapy. I'm a big proponent.
Yeah. Yeah. So, and there's another, there's a lot of stuff that's coming down the pipeline that's new and exciting. So it's an exciting time to be in lung cancer research because we do have so many things, but it also means we have a lot of things to try. It's a lot of trials. It's a lot of money. To find the best stuff, we certainly need more research funding in lung cancer to figure all this out. So hopefully I'll not be put out of a job anytime soon, and I'll, be hard at it in the lab. But I would say those are our major staples: surgery, radiation, chemotherapy, immunotherapy, targeted therapies, and sometimes cellular therapies.
What happens if someone has multiple mutations that pop up? Is there such a world where people can take two types of medicines at the same time to combat those?
Yeah, yeah, that can happen. It's rare, but I've seen
Okay.
it. And you can take a targeted therapy for one thing and a targeted therapy for another thing. And if they're tolerable together, that can happen.
Yeah.
Usually, the way we think about cancer is if it has one of these mutations, we call them oncogenes because they're genes that cause cancer, the onco part. So usually things can only have one oncogene, and like it shouldn't need another one. But that already happened. But sometimes after therapy, another one will come up, and that's how it evaded its therapy. That's how it evolved. But I've seen examples where someone has two things at once in the beginning, and lightning strikes twice. Sometimes that's
Yeah.
just how it happened. So yeah, that can certainly happen, although it's rare.
Okay. Well, this has been super helpful. I think we need to do multiples of the lung cancer ones just to dive deeper into different areas that we covered at a high level. But this has been super informative.
Yeah, I mean, every single thing we braced on here is its own PhD thesis. So, well, and we didn't really even get into all your experiences with this, and what does it feel like to go through these things, which is something I usually like to do with these kind, but lung cancer just has a lot going on,
Yep,
so we had a lot to unpack.
we did indeed.
But okay, but that just means to be continued. More to do. The job
Yep.
is never done. All right. Well, thank you everyone for listening. And, you can always like, subscribe, and then log into krakencancer.org and let us know what you want to hear. Whatever questions we missed, reach out to us on social media or through our website, and we'll get to it. Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research. Because together, we can crack cancer.